eccentric. And I am an emeritus professor now, which means I'm a retired old fart, really. But one of the great pleasures that I still have in my part-time working life is being able to visit centres like this and to interact with some of my heroes in the field, of whom Claudia Witt is definitely one. I think the work you've done in this area of CAM and integrative medicine over many years, Claudia, is fantastic. And thank you for allowing me to have some little role in this through today and tomorrow. Thank you. So that's my title, and I'm not sure how all that fits together, but we'll see. So I'm going to actually talk about 5 topics, which is a bit ambitious in the time allowed, but we'll see how we go. So just a brief introduction to some of my thoughts about expectations. Then I want to go back to my rheumatology days and talk about joint replacement. And then go on to some of the things I'm working on at the moment, which include issues like safety and validation, and then see a little bit about how this might all tie in with placebo and healing. So that's where I'm going. So we'll start with expectations. And expectations, as we've just heard from the introduction, are very important. They change outcomes. There's a massive body of work on this. Just 2 examples. If you are given a cup of coffee and you're told it's got caffeine in it, you will have a physiological response with raised heart rate and all the rest of it, as well as the psychological effects of increased attention and anxiety and all the rest, even if it's got no caffeine in it, as long as you're told it's got caffeine in it. Loads of experiments to show that sort of phenomenon. And on the other side of it, in the nocebo, perhaps some of the best examples is from trials. If we warn people in trials that side effects may occur, quite a lot of the people who've got the dummy tablet, the tablet with no active ingredient, will get those same side effects. So they've been told to expect the side effects, so they get them. So these are powerful effects. They're reproducible. Many, many experiments have shown that they occur. And the implications of this, I think, both for clinical work and for our research are huge. So when we're doing clinical work, what we tell our patients to expect, how we deal with the expectations they may have picked up from the internet or from talking to friends, all of these things are potentially going to be very important. And in our research, we have to think about how we, for example, consent people to trials. I think this is an unexplored area that really needs attention. What is the effect of the consent form? What effect does it have on expectations and therefore on what happens in the trial? So expectations, very big effects, very important in medicine and in medical research. So far, so good. But what actually is an expectation? Well, it's defined, and this is a definition from a dictionary, as a belief that something is likely to happen in the future. And of course, we all have lots of beliefs, lots and lots of beliefs about what's going to happen in the future, and they're actually part of who we are. They're part of our identity, and they're how we make sense of the world. And within that, and within areas like health, we actually have a magnitude of different ones. Some of them are big ones, and some of them are little ones, and they potentially compete with each other in the way we run our lives. So just for example, big beliefs and little beliefs in health, you might have the big belief that it's all God's will, whether you're going to be ill or not, and what's going to happen in terms of the outcome is dictated by God. That might be a high-level belief. But underneath that, you might have a little belief that actually I think, I might do better if the doctor gave me herbal remedies rather than these drugs. That would be a little belief below it. And the little belief is definitely relational in that it depends on the interaction with other people around you, and it can be changed. So it's not a belief about, you don't have a single belief about whether you're going to get better or not or what's going to happen. You have a multitude of different beliefs which are hierarchical, and some sit above others. And only some of them, I think, are easily changed in relations. So expectation is not a simple construct. So we've managed to get through part one quite quickly, so I think we'll be all right. So I'm moving to joint replacement now. You might wonder why, but we're moving to joint replacement because I've spent an absurd amount of my research career on researching joint replacement. And inevitably part of that research has been about expectations. So I just want to tell you a bit about that, just to indicate again some of the complexities around this issue of expectations. So joint replacement, good treatment for people with advanced joint disease, advanced osteoarthritis. Usually held up to be one of the best, most cost-effective interventions that we have in modern medicine. But it doesn't work all the time. It works well for most people, but about 10% of people who have a hip replacement, and actually more than 20% of people who have a knee replacement, do badly. They're either not much better or, in some cases, worse than they were before they had the joint replacement. The references here are from the team I've worked with, but there's masses of publications to show that phenomenology of joint replacement. And high expectations, or what's sometimes in this area called optimism about the outcome, are clearly associated with better results in this spread of outcomes after you've had a joint replacement. Andy Judge did that work with my group, but again, several other people have shown that. So if you get a questionnaire asking people about their expectations before they have the joint replacement, and you relate that to how they did a year later, you get a clear relationship with better outcomes for high expectations. It fits with all the other literature about expectations that we've mentioned already. But what happens if you then go and look qualitatively at what's going on? And this is confined to the UK. The UK, I need to remind you, is a small island near Europe. And probably doesn't represent anything really apart from idiotic approach to Europe. But anyway, in the UK, for what it's worth, many orthopedic surgeons, when they're talking to patients, they actively try to reduce expectations. They say things like, and these are quotes, "It's not going to be perfect, it's not going to make you 21 again." They try and lower the expectations because they believe that high expectations leads to dissatisfaction with the outcome. And again, a quote, "Well, of course he's not happy about the operation. He hoped that it would turn him into a great golfer." And these are quotes from work of Anna Sansom using qualitative research with surgeons. So in the surgical community, there's a sense that high expectations are a bad thing because it'll never be met, and it leads to dissatisfaction. No evidence that that's true, but that's how they work, and they try to lower expectations, many of them, before the operation. Well, that's quite interesting, but it's not nearly as interesting as what happens if you do qualitative work with the patients. So we asked people on the waiting list to have joint replacement how they thought they would be after the operation. That's just a lay way, really, of saying what their expectations of outcomes were. And they didn't want to tell us. And here again are some quotes. This is work by Gillian Woolhead, who was one of my PhD students. "I don't know what to expect, to tell you the truth. I don't know. I don't like to think about that." Several people said that. I don't want to think about it. I don't know. Or, "I cannot say, that would be tempting fate, wouldn't it?" There was this sort of sense of, "Oh, don't do that to me. I don't know. I don't understand all this." So they didn't want to know. And this is by no means unique, this piece of research by Gillian. There's plenty of other papers around in surgical interventions, qualitative studies, that suggest that people cannot express prior outcome expectations. They talk instead about hopes and fears. "Well, I hope the pain will be a bit better, but I'm really worried that I'll get an infection." So they're balancing their hopes and fears in their conversations to you about expectations, and they're often frightened, anxious. Who wouldn't be? But interestingly, after the event, they can tell you what they were expecting. So they may say beforehand, "Oh, I don't know, I hope the pain will be better, but I'm worried about the infection." Afterwards, they'll say, "Well, I was pretty confident that the pain would get better, so I was happy to go ahead with it. It was all good, it's all fine." So there's a complete change of concept afterwards than there was before. But of course, what we do with most of our expectation research is not talk to people to understand where they are. What we do is we give them a questionnaire with a limited number of options about expectations. And, you know, patients are brilliant. They fill in the forms, even if they think they're stupid forms. They give us an answer because we've asked them for one. There's, again, masses of research, qualitative research to show this. You give someone a questionnaire and they say, well, that's a very stupid question. How well am I? I don't know. Well, I'll tick this box, I suppose, because you want me to tick a box. This is work with the think aloud technique, where you give people questionnaires and you turn a recorder on and you ask them to tell you what they're thinking as they fill the questionnaires in. So I think a lot of our work on expectations is actually quite flawed, because it depends on giving people options within a written response which does not reflect really what they're thinking and what they're worrying about. Having said that, there are clearly some preoperative expectations and beliefs might be a better term for this, that are relational. In other words, they can change in relations and can be altered by healthcare consultations. And I want to give you one example of this, again from my work in the joint replacement field as a case study. So this actually was a professor of medicine, like me, a retired professor of medicine. We're all hopeless, aren't we? He came to see me with severe hip pain that was radiating down his thigh, and he was quite convinced that he had a terrible hip and that he needed a hip replacement. Hip osteoarthritis was in his family. His father had ended up in a wheelchair many years back before hip replacements was a standard option, and he thought that was going to happen to him, and he was frightened. But the examination and the x-rays of his hip were quite normal. So I examined him and I looked at his x-rays and things, and I thought, well, actually probably this is coming from the spine. He had some facet joint disease. Facet joint disease can radiate into the hip and thigh region, and that's what I told him. I said, look, I think it's coming from the spine, not the hip. And I vividly remember the first time I told him that. He was a professor of medicine, senior to me. I'd examined him carefully, looked at his x-rays, said, look, it's your back, it's not your hip. He shouted at me, he said, that's ridiculous, you're completely wrong, you call yourself a rheumatologist, how dare you? And he stormed out of the room. And, but he came back to see me a couple of weeks later, by which time I'd got out some literature, old literature, to show that you could reproduce hip and thigh pain by injecting saline into a facet joint of the spine. So I was armed with some evidence of the sort that I thought he would approve of, rather than an idiotic young rheumatologist like me. And again, he wasn't convinced, but he took the papers away and said, well, he didn't really think I was right, but he'd have a look at this literature and he'd have a think about it. And he rang me up a week later, and he said, my pain has gone. He said, I read that stuff, I wasn't sure, but then I woke up the next day and I believed you, and the pain hasn't bothered me since. And I used to get a crate of wine from him quite regularly after that, which is probably why I remember the story. Although alternatively it would be a reason to forget it, wouldn't it really? But so that was a placebo effect, a rather startling placebo effect caused by altered expectations and beliefs. But it could only happen when he got to a point of he could trust and believe me and alter his belief accordingly. He had to be in the right place. There had to be trust, there had to be belief. And then he could have quite a massive change in what he thought about the world, and the placebo effect, getting rid of his pain, followed. Now, unfortunately, in my view, most of our research about placebo effect just concentrates on the patient's brain. So, with respect to some people in this audience, the neurobiologists and imagers would have scanned his brain and measured his dopamine, all that stuff. The thing that interests me is the relational bit. What was happening between him and me and his reading of the papers and understanding of the world? What was that about? How did that facilitate this change that then led to strange things happening in his brain that frankly don't interest me a great deal? So it's about changing expectations, and it's about trust and belief. We never trust a used car salesman, do we? But what about this person? Show of hands, how many people feel they could trust this lady? About half of you. I mean, not sure, are you? So not sure is a good response. And what about this one? It's difficult, isn't it? And it's because actually, you see, it's all about context. It's the context they're in. It's the trappings. It's, oh, I've done something terrible. I've probably ruined the whole day. Oh, no. I was looking for a pointer, but is this the, oh, gosh. Oh, that one. I want to use this. It's, I was just going to point out to his power symbol, you see. He's got his power symbol around his neck. And he's got his white coat. He's got his symbols on, symbols of power and authority. And it's all those sort of contextual issues and other stuff, as well as the cheesy smile and the rest, that might affect this issue of whether we trust people. The fact is, we make very rapid decisions about whether to trust our used car salesman or not. It's almost like that. As you walk in the room to have a consultation with somebody, the trust issue can be almost instantaneous. I have no idea how that works. I think it's really interesting. Highly context dependent and very individualized, I think. So I think the issue of why we put our trust in some people and not others, and why we let some people alter our beliefs and our expectations, is a really interesting issue around this topic, and really relevant to whether we're going to get these massive placebo effects or nocebo effects or whatever. And I think it's really complex. It's clearly context dependent, and I don't think we know much about it. But we have been working on one relatively simple biological mechanism that might help us here in our ability to help people with their expectations, and that's the polyvagal theory. I'm going to be boring and just ask for another show of hands. How many people here know about the polyvagal theory? Okay, I see 1, 2, 3, 4 hands. That encourages me. Well, actually, it discourages me. You should all know about the polyvagal theory. Why doesn't everybody know about the polyvagal theory, for goodness sake? It's been around for a long time, but it's always the same. Nobody's ever heard of it. It really gets to me, this, you know. I don't know what Stephen Porges thinks. I can't imagine, because he's the guy who actually developed this theory many years ago, and I think it's a game changer. So it's about safety and validation. So what does this picture make you feel like? Don't write your answers on a postcard. Shout them out. How does it make you feel? Joyful, cozy, good, yeah? Safe, perhaps even? Yes, it produces a nice relaxation response in us as human beings. And there's a very good physiological reason for that. So we all know about the fight or flight response, or its extreme end of the scale, where you shut down completely. Response largely sympathetic driven within the autonomic nervous system. And that's a preservation response. But we also have the opposite built into us as higher animals, another system that's just about the complete opposite of the fight or flight, that allows us to work in groups and to nurture our young, which take a long time to mature. In the case of my own children, some 40 years. Don't tell them I said that. And that's the nurturing response, the response you get when you look at a young baby when it first smiles to you. You want to look after it, you want to nurture it, and you feel relaxed and you feel good. So that response is the opposite of the fight or flight. And the great breakthrough of understanding that Stephen Porges made was to realize how this was operated through a particular part of the vagal nervous system, and its interactions with the means of communication that we have between each other as human beings. So these systems affect how we speak, and they affect what we hear. So if you turn on a threat response in someone, if they feel threatened, they will start speaking in a monotone like this, and they will not look you in the eye, and they will not hear what you say. But if you activate the nurturing response, then they'll be all sing-song again, and they'll be able to look you in the eye, and they'll hear what you say. This is a game changer, I think, in understanding that human communications, the effectiveness of human communication, depends on whether we feel safe or whether we feel threatened. So that little girl probably feels safe, and probably so does her dad. But that lady does not feel safe. She feels threatened. And the communication will depend on this type of response. So here's a cartoon of it. It's about how we perceive our environment, and that will dictate our ability to interact with others. If we feel it's dangerous, then we won't be able to socially engage properly. If we feel it's safe, we will. Now, the question I put to you is, how often do you think our patients, and indeed our healthcare professionals, feel safe when they're in a clinical consultation? Yep, not often. Now, one of the things that makes you feel safe is to be validated. Validation and invalidation are a sort of psychobabble area of research that is an advance on empathy. So validation, you feel validated when you know that the other person understands you and has your best interests at heart. The opposite of that is where you don't feel you've been heard or understood, which of course we hear massively from patients, particularly those complaining about us. And empathy is part of it, but validation is a bit more than empathy, because it's about the receiver as well as the giver. It's about whether the other person really feels that you've understood them as much as you trying to understand them. And validation, as I say, does make you is one of the things that will make you feel safe. It's not the only, there are loads of other things that can make you feel safe or unsafe, but this is one of the things that we can play with relatively easily that will help the feeling of safety. So I guess I've already asked this question. I just got the slide in the wrong place. You know, does that sort of typical consultation story, does that suggest safety and validation? I think not. So some empirical evidence for this. So the hypothesis that another of my PhD students, Maddie Greville and Harris, ran with a little while ago is that validation of another will lead to a sense of safety and a nurturing response, whereas invalidation will be seen as threat, and that this will have the expected results on the autonomic nervous system that Stephen Porges would predict. And it does. And, oh, I missed something there probably. The experiment, first experiment Maddie did was with students in the laboratory doing an impossible maths task and then monitoring the response. So the way that we did this was that Maddie would give them this task and say, you've got 1 minute. It's a very simple task, 1 minute to do this maths task. It was completely impossible. And then when they'd done it, we'd randomize them to 3 groups. One group she didn't give any feedback to at all. She said, well, can you fill these forms in? The group who were randomized to the invalidation feedback, she said, well, goodness me, couldn't you do that? Well, that's a very simple task. I really don't understand why you couldn't do that. And the validation group, she'd say, yeah, look, I'm really sorry. It was impossible, actually. I'm sorry to mess you about that way. It's part of the experiment. No one can do that. So they were either validated or invalidated in their reaction to not being able to do the task, or one group was just given really no feedback, and she tried to stay as neutral as possible with that group. We had one smart ass who did it, actually. That's really quite boring, but you always get a smart ass if you work with students, don't you? So it worked. Basically, it worked. The hypothesis was the data went with the hypothesis. So the autonomic nervous system responses were, as expected, parasympathetic switch on with validation, sympathetic switch on with invalidation. And we did another number of other bits of work around this, including online experiments and some work, rather small amount of work, sadly, directly with clinical encounters and interviews with doctors and their clients. But it all pointed the same direction, and Maddie's published a lot of work on that. But there's one particular bit, I just put this slide in late because Claudia said I might have a few extra minutes to talk than what I'd expected. Is that still true, Claudia? So I just stuck this one slide in, and I'm going to talk for endlessly about it. Because the results do support the hypothesis in all ways. However we've done the experiments, if you validate someone, they were able to relax, they felt better, and where we were able to measure it, the autonomic nervous system switch on went in the right sort of direction. And similarly with invalidation, they felt anxious and upset, and they tended to have a sympathetic switch on, a fight or flight type response. But the really interesting thing was that the negative response was much, much more powerful than the positive one. So invalidation was fantastically damaging to people. Validation helped a bit and made them feel a bit better, but it wasn't very effective in changing things, whereas invalidation was quite stunningly bad news. And we think that actually fits with evolutionary theory as well, that because we're better primed for threat than we are for reward in evolutionary terms, our response to threat is an extremely powerful one and an extremely effective one. We sort of calculated roughly on the basis of the data that we have that bad was 5 times more powerful than good. 5 times more powerful than good. And we published that in the American Journal of Medicine last year. Just in case anybody's interested, I'm sure you won't be, but for what it's worth, that's where it is. Again, it fits in with other work in the social sciences about bad being more powerful than good. It fits with work, I think, in the educational field. We have someone in the audience who understands education, but I'm sure she'll put me right, but where the sort of feeling is that you've got to give people a lot more strokes, a lot more rewards for scolding them any one time to counteract the damaging effect of one telling off. You have to do quite a lot of repair work with good stuff. So we are particularly susceptible to threat and to bad things. It's a threat to our identity. It doesn't have to be a physical threat, something that tells you off, tell you you've done the wrong thing, something that threatens us as a person, as an intellect. We're incredibly sensitive to this, and it's incredibly damaging. And I just think this is another crucial issue for the understanding of medicine, actually, and how to practice medicine, because I think we spend a lot of our time activating the nocebo effect by invalidating people or just not getting it right in what we tell them. There's a wonderful Frenchman, the guy who invented underwater birthing. His name's gone out of my head. I'm very old. Could be. Don't think so. Anyway. Yes, Michel Adam. Thank you. Michel Adam. I heard him talking about antenatal care a little while ago. He said, antenatal care? No, we don't do that. We just do antenatal scare. All we do with pregnant ladies is scare the pants off them. Oh, you better do another scan. You never know. It could be, oh, your blood pressure's a wee bit up. Oh, we better watch that twice a day forever. I mean, it's just awful, isn't it? But I don't think antenatal care is any different from most care. We just scare people. No wonder they don't do well. No wonder conventional medicine doesn't work very well. Because all the time we're just scaring people. We are activating the nocebo response extremely effectively, and bad is much more powerful than good. The people who are good at this, getting it the right way around, include really weird people like hypnotherapists, because their training is in how to avoid negative expectations and negative ideas, and how to just work with the positive. And that's what we should learn to do. So I filled a bit of time with that slide. So, if you feel safe and listened to, then you can relax, you can trust another person, you can interact with them properly, and expectations may alter, and you can activate a placebo response as opposed to a nocebo response, which is what I've been rabbiting on about for the last 5 minutes. Or, I think, in light of what I've said, we could call it the caring response. And I'm actually on a little personal campaign at the moment to reconceptualize the placebo response as the caring response. I think it's the response to being cared for. So, placebo or the caring response and healing finally. So I hope I've shown you how caring can facilitate a placebo response. The reason that professor, colleague and patient of mine got better was I cared about him and I cared for him and I did some things that allowed him to believe that I was trying to get it right for him and allowed him, therefore, to be able to change his expectations and the meaning of his illness. And Dan Moorman calls the placebo response the meaning response. But I think, as I say, we should call it the caring response. It may be that changing meaning is one of the effector mechanisms, but I think the thing that stimulates it is caring. And I think healing, which is a very strange concept, is at least in part placebo squared, if you see what I mean, or placebo plus, and leads to a massive change that allows reintegration of mind, body and soul to occur. It's always a bit dangerous to say a word like soul in a medical audience, but there we are, I've risked it. So my current work actually with the Institute of Integrative Health in Baltimore is about trying to understand healing. And from quite a lot of work around this, we think that key characteristics of successful healers include focused attention with good intention for the other person, and they're being grounded and able to connect, which is a big subject actually what that means, but we can talk about it in discussion if there's time, otherwise don't worry about it. But what it really means, I think, is that a good healer is showing immense caring for the other person. And the healee, or the person on the other end of it, it's crucial that they feel safe and validated, or in another sense, cared for. And that, I think, allows you to bring these three parts of yourself, which are often rather fractured and fragmented, together in a way that allows you to feel healed or feel whole. So my conclusions are in the 5 issues I've tried to talk about. First, expectations, a complex construct, and crucially, at least in part, a relational one. The joint research on joint replacement shows that expectations matter and can have a huge effect on outcome, but also showed that how we elicit expectations is potentially a real problem. Then I talked about changing expectations and the importance of trust and belief in another person. And then the research on safety and validation suggests that to achieve trust, to therefore be in a position to change expectations, the clinician and client must both feel safe, and the client's experiences must be validated by the clinician. If you want one take-home message in terms of relevance to medicine and medical research, it's number 4, really. And finally, I just self-indulgently talked about placebo as healing as being a sort of squared function of healing, allowing these sort of massive changes in effectively who you are. So thank you very much for listening, and I'm happy to discuss.